teaching program for postgraduates in pathology, season 3. Today, April 4th, we're having our 50th session, which is a slide seminar on approach to liver biopsies by Dr. Siddhartha Datta Gupta, Emeritus Professor, National Academy of Medical Sciences, and Adjunct Professor, Department of Pathology, St. John's Medical College, Bangalore. This topic will be having two parts. Today, we'll be conducting the first part. Sir will be continuing the second part on the 11th of April. So these are the participating postgraduates. Dr. Sudha, can you start introducing yourself?
Good evening, everyone. I'm Dr. Sudha, final year resident from Topiwala National Medical College, Mumbai.
Dr. Pratima.
Good evening, ma'am. Good evening, sir. I'm Dr. Pratima Jarusha, second year postgraduate from BM Patil Medical College, Vijaypura.
Dr. Balamitra, can you hear us?
Balamitra is third year postgraduate from Osmania. Aditya, you are there?
Yes, sir. Good evening, sir. Sir, second year PG from Bajaj Full Singh Medical College, Thanpur, Haryana.
Good evening, everyone. I'm Dr. Ananya Indra Kashyap, final year postgraduate from Assam Medical College, Dibrugarh.
Dr. Grishma.
Good evening. I'm Dr. Grishma, second year resident at JLN Medical College, Ajmer.
The attendees can post their questions and comments, and we shall be conveying it to the faculty. So today's moderators are Dr. Aditi Mittal, Assistant Professor, National Institute of Medical Sciences, Jaipur, and myself, Dr. Leena Paul, Specialist Pathologist, Serene Lab, Bahrain. Our webinar hosts are Dr. Anita Borges ma'am and Dr. Sumit Gujral sir. These are some reminders in case of connection interruption, and one special request not to send requests for annotation to the presenters. These are some disclaimers. Sorry, a few more of the disclaimers. And before we start, we have on the 9th of April, our next lecture on chronic hepatitis bar liver diseases by Dr. Anjali from Professor of Pathology, Nair Hospital, Mumbai, following which we will be having the second part of today's session on the 11th of April by Dr. Siddhartha Datta Gupta itself. So with this, I stop my sharing, and I invite Dr. Siddhartha to share his screen, sorry, his slides.
Okay. Can you see my screen now?
Yes.
So,
Okay. Good evening. I've been associated with this right from the beginning, and so this is the third session that's going on, and I'm really honored to have two wonderful moderators, Dr. Leena Gupta and Dr. Ankita Mittal, with me today. So,
It's our pleasure.
so I would also like to thank at the outset my colleagues at AIMS New Delhi, especially Rajini, for giving some slides. I retired from AIMS some time back, and so some of these slides we're not supposed to carry, so I didn't have. She kindly gave me some pictures, and Madhu also. So I thank them. So now the way we'll go through is there'll be a lot of basic things today, and I'll discuss some slides, and tomorrow, the next session also we will continue. So this will basically be on others, and we don't get paid for anything, or neither do we do this. So now there are residents from both the next session and here. I'm so glad that they are there. We have a set of wonderful people from all over the country. So we have Aditya, Bandaru Pratima Jerusha, Girishma Tamoli, and we have Siddhartha Rana from Nepal. We have Ananya, Balamitra, Sudha, and so we have 3 third-year residents. That's why the scroll is little longer, and we have 4 second-year residents. So we'll just see how you go about it. Is
So
there
Dr.
anyone?
Siddhartha has not joined today.
Oh, he has not joined? Okay. So we'll have
So
3 and 3. So the green from Vibgyar is not there. Okay, from the rainbow. So for next time, we will the other people's names will be featured. Make out. Okay, so you just write A, B, C, or D, and your clock starts now. 20 seconds.
Attendees can reply in the chat box.
You just reply in the chat box. Okay. Time's up. So,
Sir, mostly B, some C, and few A and D.
oh, good. So B
Mostly
and
B.
C. Mostly
Mostly
B.
B.
So you see, people say less than 1 a month. That's quite a little one, no? So it will be difficult for residents after 3 years to be confident. So we'll just see how best we can go about liver biopsies. You see, this is how a liver biopsy will look like when you first see it. In some, the sections are thin. In some cases, the sections will be thick. So, but anyway, it depends on what your institution is familiar with. A little thicker section is fine. It need not be as thin as in the case of kidney biopsies. The 3-4 microns are the maximum you can go through, because you have to see the basement membrane and other structures. But only thing, you have to get used to the amount of inflammation, whether the there's a point I'll use. Whether this amount of inflammation is too much, or whether it's severe or moderate. Somebody else who sees this type of inflammation will say that this is too much. So it depends on the thickness of the section you should be in. Nowadays, it's mainly used for clarifying certain diagnoses and helping in prognosis. And of course, in tumor pathology, it's the same, grading and other things. And sometimes it's used for non-histological assessment. For diagnosis purposes,
Sir, your voice is breaking.
is it better now?
Now we can hear you.
Okay. Now, because the earlier they were all viral hepatitis, majority of the cases. Now you can diagnose them with serological tests, molecular biology tests, and there are some surrogate markers for fibrosis and severity of inflammation. So the number of biopsies have gone down in many institutions. But of course, where there are transplants, the larger institutions, you do get liver biopsies. Now, what are the types of biopsies you are going to see? Today, we'll concentrate mainly on the needle biopsies, but you do get sometimes wedge biopsies. These are taken mainly during surgery or laparoscopy. But when you get a wedge biopsy, please ensure it is quite deep like a cup and it's not shallow like a saucer. That's very important. And of course, they have to be fixed properly. So this is a wedge.
Sir, voice is not coming. Hello? So it's not getting
Well,
properly.
our voice is not clear.
Thank you.
Can't hear you, sir.
Now can you hear Sumit?
And now,
Now,
Now it's better?
Yes.
yes.
Okay. Now the thing is, what I was telling, why a wedge biopsy should be deep is because you see there's a capsule of the liver, and from the capsule you get fibrous strands which go down inside. And therefore, if you are going to see only the superficial portion, then you can mistake them for cirrhosis. You see, this is how the surface below the capsule looks like. You get a lot of fibrous bands, and this bands go on to a depth of about 5 millimeters. So your wedge biopsy should be deeper than 5 millimeters. That's why needle biopsies are always better for diagnosing cirrhosis. The second problem is just below the capsule, you often get inflammation and collapse. So why it happens, nobody knows. So if you have a shallow biopsy, you're going to make a diagnosis of chronic hepatitis. So wedge biopsies, when a surgeon gives you,
Sir, your voice is not coming still.
I'll mute and unmute. Let me see. Is it not coming?
No, sir. You unmuted yourself.
I have muted purposely. And now? Still problem?
No, sir. It's okay now.
Now it's
Oh my
okay.
God. It's okay.
Yes, sir.
I just unmuted it. Okay. So what I said was, if you're going to get a wedge from a surgeon, please be careful. Don't mistake the superficial area for a cirrhosis or inflammation. Just below the capsule, you get a lot of inflammation and collapse. Reason is not known why. For 5 millimeters depth from the capsule, you get little of these anchoring fibrils going down into the interior of the liver, and therefore if you take a biopsy, if you just see the superficial portion, you can mistake them for cirrhosis. So you have to always take a needle biopsy, which is always better, right? So this is one thing. The other thing is, Of course, technically the biopsy should be good, and always if you are in doubt, discuss with your colleagues. Then one thing you can do for liver biopsies and kidney biopsies is, if this is the cutting edge of the block, no, you always have to see serial sections. Now, if you cut the wedge at the cutting edge and ensure that where the biopsy is, the amount of paraffin all around is minimum, you tend to get more sections on a slide. Whereas if you don't trim this area, this like a wedge, if you don't make it, you are likely to get a lot of unnecessary paraffin around the biopsy. So you see, the amount of tissue sections that you get on a slide will be much more if you make a wedge and ensure that very little paraffin is all around the biopsy. Keep this in mind for all small biopsies, liver biopsies, kidney biopsies, GI biopsies, all of them. We do that so that in one slide itself we get many sections. This amount of redundant paraffin will be less when you make a wedge out of that. So that's the other thing. So this is how you get multiple sections, you examine them, right? So it must be technically satisfactory, properly fixed, and work with your clinician. The response of the liver in non-neoplastic disease is always same. You will get inflammation, you will get necrosis, you will get ballooning change and similar change and cholestasis and fibrosis. Only it's a combination of these 5 things. Nothing more, nothing less. So you have to work with your clinician and try to arrive at a proper diagnosis. It's not like a tumor where you have markers and other things to help you. Here hardly anything. Right? Now you have to remember 2 things. One, some liver diseases are diffuse. The entire portion of the biopsy is affected almost similarly. Some liver diseases are focal. They are, one part of the liver is affected, another part may be affected, other is not affected. So this is very important. So there will be sampling errors. For example, I think there's some background, something is going on. Anyway, if when there are why I'm talking about sampling errors is, for example, this is a liver biopsy. You see, if you see this, the inflammation is a little more than what you see here. So these are 2 cores of liver tissues. They are showing variation in the amount of inflammation. Actually, they are from the same core. So it depends how your biopsy needle went. So this is something you have to convey to your clinician, and your clinician also has to understand, right? So therefore, remember, these things can happen, especially in patchy liver disease. These things can happen, especially in chronic hepatitis. So sometimes the grading and staging may not match, although this is the best thing that can do. So you have to have a lot of serial sections and you have to take a lot of biopsy. Similar thing, look at this fibrosis. This is the tissue. It depends where your needle goes into, you know. Here there will be a lot more fibrosis than here. You just see, this is the same old thing. It depends where your needle went in. So remember, sampling is one issue in all liver biopsies. So what is an adequate liver biopsy? Adequate liver biopsy should be about 2 centimeters in length, and for chronic liver diseases include at least 10 or more portal tracts, right? If it is between 10 and 20 millimeters in length, you measure it properly while grossing and has 6 to 10 portal tracts, you can call it a compromised liver biopsy. If it is less than a centimeter long and has less than 6 portal tracts, then it is inadequate. All this refers to chronic hepatitis or chronic liver disease. It does not refer to acute liver disease, but because in chronic liver disease you get most of the biopsies and they are patchy, this is important. 2 centimeters, 10 portal tracts. Less than 1 centimeter and less than 6 portal tracts, it's inadequate. Between 1 and 2 centimeters in length and 6 and 10 portal tracts, it's compromised. So the reason for this, we'll come to that, why it should be more than the width should be at least 1 millimeter. Why should the width be 1 millimeter? You can get that in a 16 gauge needle. The diameter is 1.626 millimeters, and with formalin about 30% shrinkage, you will get in the slide at least 1 millimeter width. And now why should you get at least 1 millimeter width of liver biopsy? Is because the distance between two portal tracts is about 8 millimeters. So unless you have 1 millimeter across, if there are two portal tracts, you will be missing them, right? So 1 millimeter width, 20 millimeter in length with 10 or more portal tracts is the best liver biopsy for chronic liver disease. I hope that's understood. And how do you get 1 millimeter? Use a 16 gauge standard 16 gauge needle for taking the biopsy. You see, the distance between central vein and portal tract is 0.8 millimeters. Therefore, you must have a 1 millimeter width of liver biopsy. Lengthwise it's okay, but widthwise you have to have 1 millimeter. Having said that, for amyloidosis you don't require much. Even a tiny bit of tissue is enough. This is a post-mortem biopsy. The resident just took a small biopsy, the skin and a wee bit of liver. The amyloid stain was positive. It was there even in the skin, so it's perfectly okay. So for that you don't have to worry about 1 centimeter, 2 centimeters and all that. It will give you your diagnosis. Now please view this slide. Can I have one of the second year PGs? Who will volunteer? Second year, who is there? Anyone? Who will volunteer? Second year PG, anyone? Or shall I call out the name? Huh? Anybody? Okay, I'll put the slide. Come on, you just see this slide. What are you seeing? Grishma, what are you seeing? Yes, Grishma, please tell.
Oh, yes, sir.
Yeah, can you tell me what are you seeing?
Sir, there is a central vein,
This one? Okay. Okay.
and we have that hepatocytes, cord of hepatocytes,
Mm-hmm.
hepatic plate.
Mm-hmm.
Also,
What is this area and this area?
which one, sir?
This. Can you see the laser pointer, ma'am? Yes. This one.
Portal. This is portal.
And this is portal tract. Why do you say they are portal tracts? And why do you say this is central vein?
Central vein is it, in portal tract we can see three main structures: bile duct,
Can you
hepatic
see?
artery.
Can you see in this far?
It's not visible
So
clearly.
you'd like to go higher far? Okay. This is the central vein. Okay.
Yes.
So what are you finding here? Why do you say it is the central vein?
So it is lined by with
Yeah. Okay. See, there are two things you must remember. The central vein, generally, you will never get a round one, you know. It's irregular, it's dilated. You'll get a lining of endothelial cells. You may find little bit of collagen if you do a meson trichrome or something. And it around the central vein is the only area where you can get cords of liver cells that may radiate. Others elsewhere, no, the liver cells are never straight. You see, this cord goes there, it turns here. It goes here, it turns here. You see this sinusoid? It is always bent. It is never straight like what you show in undergrad. The only place where it is a little straight will be around in the centrizonal area. You see here it is straight, here it is relatively straight, here it is relatively straight. The reason why it should be irregular elsewhere is because, you know, in the sinusoids the blood has to flow slowly. Only then will the Kupffer cells and other cells do their job of removing effete material and anything else, and their immunological.
Sir, your voice is not coming.
No, what? Wait, 1 second. I'll just change my. Can you hear now?
Yes,
Now?
sir. Yes, sir.
Now is it better?
It's good, sir. Better.
It's good now. Okay. You see, the sinusoids are always irregular. That is because the blood has to flow very slowly so that proper exchange takes place, and the immunological reactions of the Kupffer cells and all. It has to identify various antigens and other things. It cannot happen if the blood flows straight fast. Okay. So this is very important. Portal tract. Yeah, now tell me.
yes.
Portal tract, how do you identify?
So in portal tract, we have that hepatic artery and
Which is the artery, ma'am? This one? This?
and bile.
This? Which one?
How can I point? So it's
This one? Or this? Or this?
no. The bigger one is it
This
vein.
one? This one? Okay.
Yes, sir.
This is
And
the
that
artery.
that endothelium lined one is bile duct. That
Uh-huh.
it lined one is bile duct, and the this one is artery.
This is the artery. Okay. Yeah, anybody else? Any second year, anybody else? Anything you want to say? You agree with what Grishma has said? Pratima?
Hello. Yes, sir.
Ah, Pratima, do you agree with what Grishma has said?
Yes, sir. The bigger
Okay.
lumen is vein, sir. Lumen, which is
Ah,
bigger
yeah.
one.
You see, how you identify is in the portal tract,
Lumen.
first of all, there will be a lot of fibrous tissue, which was not there. Then in the portal tract, there will be, just a minute, I'm just trying to increase this. Is it better now?
Yes.
Yes,
Huh?
sir.
Sound is better. Thank you. Okay. See, in the portal tract, the largest open structure is the portal vein, right? Then you will find
Yes.
two structures that are of the same diameter, almost same. One is the artery, other is the bile duct. They are both of the same diameter, approximately same diameter. Now, how do you identify the bile ductule? Will have these epithelial cells. You can find a lumen, maybe a brush border also, the small lumen, right? And you will have a lot of large rounded nuclei, which you can see even in this part, compared to the endothelial cell, which are very flattened and small. Okay, and then you see this, these nuclei are towards the basement membrane, and here you will find a lot of this part of the cytoplasm epithelium of this. Right? You see, this looks completely different from that. Right? That is one. Secondly, the bile duct and the artery grows together. Very important to note. This. And then you see three diameters of the arteriole, and you make a circle. Very near within that circle or on the circumference of the circle, you are going to identify the bile duct. Very important. Within about approximately 3 diameters of the artery, if you search anywhere in the portal tract, you are likely to find the bile duct. The reason is bile ducts and arteries grow together embryologically. They are very near to each other, right? So a structure in the portal tract will have three things. This large thing is the vein, this is the bile duct, and this is the artery. It has got three structures, that's why it's called portal triad. Portal triad. Triad means three things are there. In all sections, you will not find all the three. So therefore, you may get only two structures. In that case, it is called a portal dyad because it has two structures. Invariably, you can get the vein missing or the bile duct missing. Now here that's very important. We'll come to that later when we talk of vanishing bile duct disease. The second thing that you see near the central vein, you are finding this yellowish pigment here. Yeah, all of you have you been able to identify this pigment here? Huh?
Yes.
Yeah.
Yes.
This pigment is spheroid pigment. As the person grows older, you will find a lot of spheroid pigment, mainly in the centrizonal area. Okay, so that is another way of finding out the area around the central vein. So these are the ways by which you identify. There's some spheroid pigment here also. Okay, they are diastase pass positive. Okay, now Aditya, you have been able to join.
Yes, sir.
Okay, Aditya, now tell me what are in the liver. You see, there are two ways by which you can describe the liver. The original way was Kernihan's lobule. The area around the portal tract is called periportal. Area around the central vein is called the centrizonal. Central vein is also called terminal hepatic venule. And the area in between is called midzonal. Periportal, centrizonal and midzonal. Now what is this one, Aditya? Zone 1, 2 and 3?
Sir, this one is the zonal.
Yeah. Do you know what is zone 1, zone 2, zone 3? Okay. Aditya, anybody else is there? We'll go to the third year ones now. Okay. Third year, who all are there?
sir. Ananya.
Ananya, tell me, what is zone 1, zone 2, zone 3?
So this has been proposed by Rappaport. It is also like zonal theory only. The zone 1 is periportal, zone 3 is centrilobular, and zone 2 is mid-zonal, sir.
Yes, very good, Ananya. Yes, Rappaport, you see, this periportal, midzonal, and centrizonal was based on the understanding that central is the terminal hepatic venule and the entire lobule is arranged like that. Okay. But then Rappaport said that the blood flows from the portal tract to the central vein. And therefore, there will be 3 zones of decreasing blood supply or decreased oxygenation, you can say. Zone 1 is like these are like small berries, you know. So zone 1 is just adjacent to the portal tract. Zone 2 is like a berry here in between, and zone 3 covers the outer part, which includes a part of the region near
The
the
hepatocytes, sir. Who is it?
yeah,
Hepatocytes, sir.
these are hepatocytes. We are talking about hepatocytes. Okay, so zone 1 is approximately periportal, zone 2 is approximately midzonal, and zone 3 is approximately centrizonal. Now the thing is that if you see this, this is one water, this is one supply zone 3 and another zone 3 will be somewhere here. So this will be a watershed area, you know. So that is why wherever there is necrosis, ischemia, so on and so forth, you get rounded contours. The cirrhotic nodules are rounded, most of the things are rounded. So that is why this zonal phenomenon explains that physiologically much better. Secondly, it has been found like alcohol dehydrogenase is mainly in zone 3. There, uh, the enzymes that metabolize tetracycline and phosphorus are mainly in zone 1 and so on and so forth. So therefore, you know, this zonal one is physiologically more compatible than this zone 1, 2, 3. Now, when you are describing a slide, if you want to describe something in this region, you can use centrizonal, perfectly all right. But nowadays, people prefer to write whatever you are seeing in zone 3, zone 2 or zone 1. You can also use periportal, midzonal or centrizonal, but that is gradually falling out. Most of the people are now shifting to zone 1, 2 and 3. Now when you are reporting, should you start from the portal tract or central vein? Ananya, Sudha, please tell me. When you are reporting a liver biopsy, should you report this portal tract first or central area first? Which one? Sudha, what do you think? Sudha, Sudha, can you hear me? Sudha is not there. Balamitra? Balamitra? You're not
So
here?
Sudha is here.
Sudha, tell
Yes,
me,
sir. Yes, sir.
should you start writing your report starting with the portal tract or the central vein, central area?
From the portal track, sir.
Okay, Balamitra, what do you prefer? What is
So from the portal tract.
Balamitra? Okay, you see, there is no rule saying that it has to start from portal tract or central vein. Okay, you can start wherever you want, but since most of the liver biopsies are done for chronic hepatitis or chronic liver disease, and because the maximum inflammation is and fibrosis starts in the portal area, most of the people prefer to start from the portal tract. but there is no hard and fast rule. Nobody is going to penalize you if you start from the central area or what. Very good, good. So this is portal tract. Okay. Ananya, you have told. Okay.
Yes.
Balamitra, tell me what is the limiting
Yes,
plate?
sir. So limiting place is the hepatocytes that is found near the portal tract, sir. And
Okay.
they'll be thicker when compared to the hepatocytes seen in the central perivenular area, sir.
Uh, okay, Sudha, what is it?
A limiting plate is an imaginary line which is drawn outside the portal tract, which separates the portal tract from the adjacent hepatocytes.
Right. And who else is there? Okay, Ananya. Aditya, what is this structure? Okay, any of the students from the next batch, second year, can you tell what this structure is? Anybody? Anyone? Huh?
So it's
Huh?
a bile. It's a bile duct.
And this one? This
It's a
structure?
hepatic.
Mm.
It's a
This
hepatic.
one? This one?
So it's also a bile.
Bile duct.
This
Bile
one?
duct.
This one?
Uh, it's a
Portal
portal.
vein.
Huh?
Portal vein.
It's a
That's a
portal vein.
portal vein.
Yeah, this is also this one? This
Also
structure?
portal vein.
It's not bile duct. Very good. So these large wide structures, get it into your mind, they are portal veins. And you see the artery and bile duct are very near each other. Within 3 diameters of the artery, you will find a bile duct. And they are of almost equal diameter. Okay? So this is fine. Very good. So you all have understood this. Once you identify this, the rest becomes very easy. Yeah. You see, this is the liver from a pig or a swine, you know. There is a nice fibrous tissue from the portal tract joining another portal tract, and you see, this is the central vein. You see, the lobules are so nicely demarcated, but in human beings, it does not happen. You see, in this human being, it is never like that. You can't demarcate one lobule from the other. That thing is not there. So therefore, you have the limiting plate, as someone said. It is actually the last layer of hepatocyte that surrounds the portal tract. So this forms a boundary, and that is the limiting plate. Okay, last layer of hepatocyte. And this is actually the boundary between hepatic mesenchyme and hepatic parenchyme. The boundary between the hepatic mesenchyme and parenchyme, or the last layer of hepatocytes around the portal tract, is the limiting plate. If the limiting plate is destroyed, you call it piecemeal necrosis, okay, or interface hepatitis, right? So that. So please remember the portal veins may be absent in about 30% of cases, hepatic artery 9, bile duct 7, because of sectioning, nothing else. Because of sectioning, it can be absent. So on an average, you should find 2 bile duct, 2 hepatic artery, 1 portal vein per tract. Now here, please remember, you will be asked to find out in certain diseases like primary sclerosing cholangitis, transplant rejection, graft versus host disease, alpha 1 antitrypsin deficiency, and so on, Alagel syndrome, and so on and so forth, whether the bile ducts have vanished. In those cases, the bile ducts will not be there. So, how will you identify that? you identify about 10 or 20 portal tracts with arteries and count how many bile ducts are there. If the ratio of portal tracts with arteries and bile ducts is less than 0.5, that means out of 10 portal tracts with the arteries, if you don't find bile ducts in more than 5, it means there is paucity of bile duct. If there are 4, that means there is paucity of bile duct. If there are 6, if there is 5, 6 or 7, that means it is suspicious for paucity. If it is 8, 9 and 10, then of course the bile ducts are normal. Okay, this is very important. Okay, so this is, you see this, most of the liver biopsies you are not going to see the sinusoids. Sometimes you see, sometimes you will not see. And they are not going to be parallel like what an undergraduate draws. Okay, they are 2 cell thick in the case of children and 1 cell thick in the case of adults. Okay, 2 cell thick normally in the case of children or in the case of regenerating liver, the hepatic cords. 1 cell thick in the case of adults. If it is 3 cell thick, then what is it? Ananya, if the hepatocytes are 3 cell thick, their cords, what is it?
Hepatocellular carcinoma.
Yeah. If it is 3 cell thick, it is always hepatocellular carcinoma, 3 or more. Remember that. Okay. So now so it's like a neuralium on the wall. What are these? What is this? Yes, Sudha? Yes, what is it? Huh?
Polycystic. Sir,
Anyone?
polycystis.
Polystasis. Is it normal?
Bile plugging.
Will you see this bile normally? Or will you
No,
see bile canaliculi in between the hepatocytes normally?
no,
See,
sir.
normally you will never see bile. Take it from me. No bile should be seen. If it is seen, it is abnormal. Okay? Bile canaliculi are also not seen. So what are bile canaliculi? You see, the 2 adjacent hepatocytes, no, they form like a cup, and the 2 adjacent surfaces join together to form the bile canaliculi. The other surface, you will have the endothelial cells here and the blood here. Okay, right? So I'm just removing these, separating these to show you how they form. You see, these are the 2 surfaces of hepatocyte. This is half the canaliculi. This is another half of canaliculi. They join together to form a small canaliculus like this, and adjacent hepatocytes, it keeps on growing till you reach the portal tract, from the central vein to portal tract. Okay, please remember this. Now this side, Grishma,
Yes, sir.
this is an
Yes, sir.
endothelial cell. This is endothelial cell.
Yes,
In
sir.
the hepatocytes, are the endothelial cells continuous or not?
No, sir. They are fenestrated.
Okay. In an artery, are they fenestrated or continuous?
In our artery, they are
Ananya,
continuous.
do you have a
Continuous, sir.
huh?
Continuous, sir.
Yes.
So what is the difference between the two? If they are continuous with a basement membrane, and if they are discontinuous without a basement membrane, what do you call those two structures? Yes, anybody from the next batch? Quick.
So, discontinuous, like fenestrated without basement membrane, is called canaliculus. Continuous with basement membrane is artery.
Okay. You are right, more or less. Continuous with basement membrane is seen in a capillary or an artery or a vein. Discontinuous without a basement membrane, you call it a sinusoid. So you see sinusoid in the liver or in the spleen. Okay. So this is sinusoid, and here there is this blood is flowing. What is this blue area? Huh? Yeah. Yes, yes, that is the space of decay. And in this space of decay, you have the Ito cells or fat storing cells, and you have the Kupffer cells also. Okay. So here, there. So they are in constant touch with the blood, and other things. And so you have one surface of the other surface of the liver attached to each other. And so you have one a canalicular surface and another is a sinusoid surface. So in the canalicular surface, if the portal tract is here, the bile is flowing like this and the blood is flowing like that. So in opposite direction. So it's almost like a counter current mechanism that you get in the kidney. In the kidney, urine flows in one direction and the blood flows in another direction in the loop of Henle, no? It's almost similar to that. It's not exactly counter current because they're not very close to each other. You have a thick hepatocyte cord, okay? So this is how the canalicular forms. You will not be able to see it normally. You will see it only later. Okay, now see this slide. Who will see? Third year. Either this time or next time. Anyone can answer. What is this structure likely to be? Yeah.
So it's the portal tribe.
Very good. Portal tract. Very good. Okay. What are you seeing? We'll go on to hyper. What are you seeing? These are the sinusoids. Yeah. What
So
are you seeing? Anyone?
inflammatory cells, lymphocytes.
Lymphocytes. All okay. Yes. Anybody else? You're seeing this cell? Let's go. This is a higher part. Tell me now. Anybody? Anybody? It's open to all. Anybody written anything in the chat?
Extramedullary hematopoiesis.
Who is that? Medullary hematopoiesis?
So
Huh?
extramedullary.
Who?
RBCs, extramedullary hematopoiesis,
Yeah, yeah, yeah.
mononuclear
Say
infiltrates.
RBCs, you can see. Okay, this is extramedullary hematopoiesis. Look at this dark nucleus with a little bit of pink cytoplasm here in all of them. Okay, so this is mainly extramedullary hematopoiesis, and there was a megakaryocytes in the previous one which was there. Okay, so this is extramedullary hematopoiesis. Okay, see, look at this megakaryocyte. Okay, right, right. Seeing this. So this is extramedullary hematopoiesis. When you find a megakaryocyte, it becomes easy. See, okay, right? Extramedullary hematopoiesis. These are all the erythroid series. Dark inky blue cytoplasm with the eosinophilic. So what would you like to know next? Bilirubin, hemoglobin, age of the patient, nothing else. I am not putting a
Age of
stop clock.
patient.
Only 10 seconds.
Age of the patient.
Age. Age of
Age
the
of the patient.
Okay, why? Why?
neonates. Neonates, infants and
Younger
neonates can have
children.
extramedullary hematopoiesis.
No, do you know it is neonate or adult?
No,
You see here in this one now, see it is two cell cord thick. See one
yes.
line of nuclei, one line of nuclei. You see this is seen in regenerating liver, okay, or in neonates, right? And you see this bile ducts and all are small. So you see this two cell cord thick, two cell cord thick. These. So in low power, when you see this, then you think it's neonate. Okay, yeah, see, we'll see adult ones, then you'll realize the difference. Okay, so age of the patient. Yeah. So normally till what age will you get? Till what age will you get? Anybody? Anybody's made that?
Sir, in chat box, some are saying 1 month, some are saying 6 months, one is saying 2 years,
Okay,
3 months.
okay. Yeah, okay. Anyway, you see there's some bit of hemosiderin also, okay? Hemosiderin. And please note this nuclei and all, no, in children sometimes you get, don't think they're dysplastic or anything, they are part of the normal thing. And look at this megakaryocytes. Okay. You should not mistake it for cytomegalovirus, please. Okay. Cytomegalovirus, you see, this is much larger. And you can do a stain if you are very scared. Now, cytomegalovirus, normally, no, if you are to be sure, the nuclear inclusion should occupy at least 75% of the width of the nucleus. You see, this is almost 3/4. If it no nucleus will be so large, except maybe Reed-Sternberg or some malignancy. If it's cytomegalovirus, you'll be sure if it is 70. So this is a neonatal liver, and up to which, how many after birth? Some said 6 months, some said 1 year, no? Let's say.
1 month, sir. Some saying 1 month, 6 months, 2 years,
A, B, C,
3
D is
months.
there, no? Yeah, what have they written?
Sir, few are saying A, few are saying B.
Okay. Actually, this is how the hemopoiesis goes on. And those who have written 5 weeks will get the maximum marks.
Sir, your voice is not coming.
No.
Yes, sir, good.
Okay. You see, hemopoiesis goes on for about 5 weeks after birth. After that, it decreases. So those who have written 5 weeks will get maximum marks. Somebody has written 2 months, a little more than 2 months or 3 months, that's fine. You can get very little. 5 weeks is the answer, right? Are there any tumors where EMH may be seen? Anywhere in the body? Just out of the way. Write in the chat box.
One is saying chloroma, hepatoblastoma,
Okay.
renal cell carcinoma,
You see, this is a big
myelofibrosis.
list. You can see in so many tumors, you can see EMH. Cerebellar hemangioblastoma, hemangiomas, hepatoblastomas, leiomyomas, pilomatricomas, hepatic angiosarcomas, endometrial carcinoma, meningioma, hepatic adenoma, spindle cell lipoma, liposarcoma, myofibroblastic tumor, renal tumor. So whole list of tumors are there, but those who have written hemangioblastomas, hepatoblastomas, and some of the renal tumors are fine. These are okay. But you can get it in many tumors, right? Now, how do you differentiate EMH from CML or other things? One is morphology, right? You have to do this one, and then of course immunohistochemistry. Usually CD34 and 117 TDT are absent. Okay, and if you get CD34, 117 is quite common in the neoplastic, CML or some other. They're very important, right? And if there is unilineage proliferation, it's mainly erythroid. Here, if you see in neoplastic CML and all, if it is unilineage proliferation, it's mainly myeloid, right? And megakaryocytes are usually dysplastic. These are the two main things that you have to see between benign and neoplastic, right? Very important. You can get eosinophils or myeloid precursors more in neoplastic, dysplastic megakaryocyte. Here mainly erythroid, like you saw in this case, and normal megakaryocyte. CD34 117 absent, may be present. Okay, view this slide. Yes. Now, who will tell this? Aditya, what is this? Aditya, can you tell? There is a lot of crosstalk going on now, so there's disturbance. Aditya, Aditya, can you tell what this is? Madam?
Sir, I think Aditya is not there.
Okay. Anyone else? Come on, anyone else? Even from the next batch. What? Come on, tell me what has happened to this liver? This is adult or child? You see, this is an adult because you see the single cell. All these are all, they are not double cell plates. They are all single cell plate, even in this. Okay. What is this structure? This structure, black. Anyone? And white. Grishma, what is it?
Sir, central vein.
This is which? White is what? Central vein, and this one? Yeah? What, Balamitra? What is it? This one.
Black is portal, sir.
Okay. And
Yeah.
this is central.
White is central
And
vein, sir.
and you see what has happened here? The cells have all separated out, no? What is this structure likely to be?
Central
Huh?
Central vein.
Yeah, little bit of fibrous tissue there. And that structure will be the portal tract. Okay. You see what has happened here? The single cell plate thick, but they've all separated. See? Yeah, this is a single cell plate. What is this? These are the capillaries and endothelial cells, and they've all separated. This must be a capillary, no, endothelial cell, and this is the space of Dissay that's become so prominent. See all this. See, this must be a capillary here, and this is the space of Dissay. Why has this happened? This is because it's an autopsy specimen fixation artifact. Okay. Have you realized? So now you can identify what is space of Dissay. You can identify a single plate thick hepatocyte, as well as you can identify the double cell plate. So you have identified a child.
Sorry, your voice is still not coming. Again.
Now?
Yes, sir. Good.
Okay.
So,
Now you
okay.
see this, by this time you should identify a child's liver, 2 cell plate, EMH, and so on and so forth. You should be able to identify a portal tract in the central vein in adult and a child, and you have to identify an adult's liver because it's single cell plate and the artifact in an autopsy. And so you now have realized what is the space of Dissay, what is the sinusoid. Okay, so that's good. So now with this, now let us go to case number 1. A 17-year-old male presented with abdominal pain, jaundice, tender hepatomegaly, 4 weeks duration. AST-ALT is more than 1000, ALP is 322, 320, and viral markers are negative. Okay. Now, who is there? Aditya is gone. Balamitra, I see all of them are
Yes, sir.
speaking, no? So, can you tell me, is AST-ALT increased or decreased?
Increased.
It is markedly elevated, sir.
It's
Oh,
markedly increased, sir.
okay. Sudha, ALP is increased or decreased?
It is moderately increased, sir. 320 is almost normal.
Okay, right. That's also. And then, so what is not there? In this LFT, what is not given?
Total
Bilirubin
bilirubin,
is not given, sir.
total
Bilirubin is not
bilirubin.
given. And then you don't know the proteins, no? Albumin,
No,
globulin.
sir. Yeah.
Is it important to know albumin and globulin and other things?
Yes.
Why?
But synthesis,
Synthesis, so what?
Obstructive, non-obstructive
um,
process.
No, that is true. Alkaline phosphatase is raised. It may be obstructive or any other reason. Anybody else can tell me why is albumin important? Anybody, even from the next batch, please. Ananya?
Yes. So
Yeah,
hepatic
yeah.
synthetic function.
What does it tell you if it is reduced?
Hepatic
Hepa-
injuries.
Injuries there. Okay, Teresa, you wanted to tell something, no, Teresa?
So I also want to tell that the synthetic function of the liver has been
Yeah.
compromised.
That's fine. At the level of undergraduates, all your answers 100 on 100. But now tell me, as a PG, what extra will you tell? Okay, I'll give you that.
Sir, one student is saying, sir, your voice is not coming. Hello, sir. Your voice is not coming, sir.
No, why it's not? Now?
Yes,
Now
sir.
is it coming?
Now
Okay.
is
Okay.
coming.
I am telling you, as a PG, you will tell it is a chronic liver disease. Why? Now tell me the reason. Okay, I'll give you the answer.
Sir, one answer
Ye-
in chat box.
Yeah,
Albumin globulin ratio reversed in cirrhosis.
yeah, very good. It in
Sir, your voice again gone. Hello? No,
hello.
sir. Yes, sir.
Now is it come?
Yes, sir.
Okay. Okay, it is decreased. Albumin is reduced in chronic liver disease. Now, can you tell me how you can explain that? Okay, I'll tell you the answer. The synthetic function is decreased. The half-life of albumin is about 21 days or 3 weeks. Therefore, if in a long-standing liver disease, not acute liver disease, in a long-standing liver disease, the albumin will decrease. because the half-life is about 3 weeks. By about 6 weeks, 9 weeks, 10 weeks, albumin becomes lesser and lesser. Okay, so that is why albumin is a good marker of chronic liver disease. For acute liver disease,
Sir, your voice is not coming again.
again now.
Yes, sir.
No,
Now
I
it is.
don't know what. Okay, for acute liver disease, what will be a good marker in addition to all this?
Answer.
Huh? Anybody? Yes, Grishma, Palamitra, Ananya. Who else is there? Anybody from the next batch? See, for acute liver disease, a good marker will be a prothrombin time. That gets much decreased. Okay. The coagulation factors, they have very short half-life. So they are good. Okay. Now tell me, come on, one of you describe this. Who will describe? Grishma or Sudha, please describe.
So we can see there are two linear core liver biopsies.
Who is telling? Sudha. Okay, yes.
Sudha.
uh.
Yes, so there are two
I
linear
think
core.
I think one thing, no, others just mute, Whoever is speaking can unmute and start, because what is happening is there's some back talk going on and all, no, it may be creating problem. Yes, okay, Sudha, you please tell.
Yes, sir. There are two linear core liver biopsies.
Very good.
And we can see there are large confluent areas of necrosis, and there are other areas of preserved intact viable hepatocytes on either side.
Okay.
And you can also see some inflammation.
Okay, very good. Now
Yeah.
tell me, Sudha, what is this area?
Portal tract, sir.
Portal.
That area.
Lot. What is this area?
That.
Okay, what is this area likely to be?
That is also
Portal tract.
portal tract.
This area?
That's again a portal tract.
This area? Some spaces you're seeing, no?
Yeah.
What is this?
That's also portal tract.
This area? Likely to be?
Vein.
Vein. This
Vein,
area?
yeah.
This area?
Inflammation.
What is it likely to be? This area, this area. These are what? These are
Intact hepatocytes.
hepatocytes. So this and this area, what do you think they might be?
Portal tracts.
Portal tract. So you're finding in this one low power field, one portal tract.
How many portal tracts?
Vein, 2, 3, 4, 5, and what you don't know, 5 or 6.
Six portal tracts, sir.
6 portal tracts. So what do you think the patient would have happened to the patient? In a low power, you're seeing so many. This is in 10x. 1, maybe 3. So what do you think clinically how the patient would have presented? Clinical examination, what will they find?
10.
Huh?
Tenderness will be there, sir. Necrosis, abundant areas of necrosis. Tenderness.
What else? Yeah, you're finding that much tenderness is not there, because if it is enlarged, then it is tenderness. Is the liver enlarged or it will be shrunken? You're seeing so many portal
Shrunken.
shrunken. Yeah.
Yes, sir, shrunken. Yeah.
So if they do a liver span by percussing on the mid-axillary region or anterior axillary line, the liver span
Yeah.
will be decreased. If they do an
Yes.
ultrasound, the size of the
The
liver will
size will
decrease.
be reduced.
If they do a CT scan, the size will be reduced. So when the liver is shrunken, no, like this, with
Yeah.
so the patient is likely to be, if it is not cirrhosis, you think this is not fibrosis, no? These nodules are
No.
there. Do you
No.
think this is? We'll see what they are. Okay.
Yeah.
So the
Yes.
patient is likely to be in liver failure. Okay.
Liver failure.
Hepatic failure. Very good. Right. Okay. So you see, this is the portal tract. What is the seeing,
Yeah.
no? And
Yes.
in this far itself, you can see there's likely to be some cholestasis. Something is inside, no?
Cholestasis. Yeah.
Okay, here, and here you don't know. It's not
Yes.
fibrosis, no? You're sure?
No, it is not fibrosis.
Yeah. So what are you seeing here? What are you seeing, Sudha?
So you can see the intact viable hepatocytes. The there is some inflammation.
Mm.
And also there is some bile plug.
Okay. I see
Yeah.
there are these hepatocytes. Okay.
Yeah.
These
Yes.
are all bile. You know this
Yeah.
dot like bile.
Cholestasis. Yes.
This is all
There is
about,
hepatocytic.
see, these are all necrotic, apoptotic hepatocytes. This nucleus will go off in some more time. See, this is another,
Yeah.
this is another. And here, you see, these are sinusoid because there are RBCs here, no? RBCs here,
Yes.
you see. So, these sinusoids have come close to each other without any hepatocytes. So, this is one way by which you identify this necrosis. Okay. And they may not be fibrosis. This may be necrosis because you're finding this small apoptotic, like small
Bodies.
hepatocytes, and this. And then here there is cholestasis, right? You're finding.
Yeah.
So
Yes.
these are signs of liver cell injury. So you're finding cholestasis, necrosis. The sinusoids have come together. No hepatocytes in between, right? You see this in the higher part.
Yeah.
You see this? This is a necrotic
Yes, sir.
hepatocyte.
It's
This is
necrotic
another
apoptotic.
necrotic. This is necrotic.
Yeah.
Why is there so much of apoptosis in the liver? Why? Anybody else can say? Anybody else? Anyone else? Anyone from the second?
Sir, is it viral hepatitis?
It's more likely to be
Viral
viral
hepatitis.
because most of the hepatic injury that we see are viral. And one of the ways by which the viruses uh, get rid of is through apoptosis. No? So that is why you get a lot of apoptosis. Okay? So you see there's a lot of apoptosis. This one is collapse. These hepatocytes are almost going. And you see there's some places it's two cell thick, no? It is trying to regenerate. The liver hepatocytes are trying to regenerate. This is all cholestasis. When you see cholestasis, it is abnormal. You see here, this is all necrotic. The sinusoids are seen and they're all collapsed. That's why the liver cell. See here, you're finding actually sinusoids only with RBCs.
Yes.
Nothing in between.
Yes.
This you will not get in cirrhosis. Okay. This is how you identify necrosis. And
Necrosis.
this necrosis, we saw, you see here, this is the area of necrosis. This is near the central vein. Okay. So now
Yes.
we find that this necrosis is from say one portal tract to another portal tract. Okay, and here it is going from. So this type of necrosis is from central vein, portal tract, it is going, and here from one portal tract is going to another portal tract. So when there is necrosis between one vascular area to another vascular area, it is called bridging necrosis.
Bridging.
So there is acute hepatitis with bridging necrosis. And maybe in this area, the entire lobule has gone. You see this central vein? This is this. So entire lobule has gone. So this will be a pan-lobular necrosis. When the entire lobule is gone, pan-lobular. But here it is predominantly bridging necrosis. So bridging necrosis, portal to portal and portal to central, central to central you can get. Portal to portal, portal to central, central to central. These are the different types. Which will be worse? Which will be worse? Portal to portal, portal to central, or central to central? Anybody, anybody? Anybody from the next batch, anyone can tell. Anyone in the chat box? Yes, Balamitra.
Is it portal to central, sir?
Why? Why?
Portal to central.
Why? You're right. You're right. You're right. Why?
But drainage is from portal triad to the central vein.
So
There is a necrosis that will be.
Sir, your voice
You're
is
not
not
audible.
coming.
offline classes. Now a portal. Now you can hear.
Yes, sir.
Okay. Portal to central. If the blood flows, it means there is a shunt between portal and systemic circulation, because it is just flowing to the systemic circulation without encountering the liver. The liver will metabolize, will remove lot of the unwanted material, will not go into the details. And so lot of things happening. So that is worse. You are absolutely right. So that is worse. So then you do a reticulin staining. See, in a reticulin staining, it's very difficult. Can you tell this might be like a cirrhosis also, no? This fibrosis and all. But actually, if you see, this is not fibrous tissue. This is just a collapse of the reticulin fibers. You know, normally it should be white. They're becoming near because of the bridging necrosis, and that is why you're seeing. See, yeah. Hmm? Right. So this is how you get in cirrhosis. Here it is like this. Okay. Mason trichrome, there is no blue staining actually. See here? This is the necrotic.
Just clear.
Sir, your voice is still. Hello?
No.
Sir?
Hello. Hello.
Yes, sir.
Yes, sir.
Hello.
Yes,
Okay.
sir. Now we can hear.
Yes, sir.
I put the microphone inside my mouth now. Okay. It's literally resting on my lip. Okay. Now, if I stop talking, it means I've got a shock and I'm dead. Okay. Now tell me, would you like to perform any other special stain? And what is your diagnosis?
Yes, sir. I would like to do Orsi
Why?
because Wilson's disease can also present as acute hepatitis, as a fulminant hepatitis. And
Okay. Anybody else wants to do any other thing? Anything? Anything? In the,
So
any?
pass.
Be short.
Pass D.
Pass D. Okay. Anybody else written anything in the chat box?
No, sir. Nothing.
Okay. See, you can do an Orsin stain. The reason why you do Orsin stain is, see, in Orcine is normally elastic tissue which is present only in the portal tract. It will go outside the portal tract only when there is fibrosis. This is Orcine stain in cirrhosis. Okay. And this is Orcine stain in this case where there is necrosis. See, Orcine is confined only to the portal tract. Okay. It is not there in the area of necrosis. So if you have a doubt between cirrhosis and necrosis, better to do an Orcine stain. So this is acute hepatitis with bridging necrosis. Well done, Sudha. I think you have answered well. And all the others also have put in good. Good case note. See, this is Grishma, what is this? Another case. Grishma.
Yes, sir.
Ah,
So these are hepatocytes with clearing of cytoplasm,
very good. What else?
and also we can see inflammatory areas.
Yeah, all this. What is this area, Grishma?
This
What
is
is it?
portal type, sir.
Very good, very good. I am so happy you people are able to identify portal tract and central vein and all. That's more than enough for a day. You know, this is ballooning. This is also acute hepatitis with bridging necrosis, except that the cells are ballooned here. Okay, so you have different types of necrosis. One necrosis in which only few cells. Okay, what is that called? Anybody? Huh? Necrosis
Spotty
with
necrosis.
spotty or
Spotty necrosis.
spotty or focal. Group of cells, then you call it
Confluent
confluent.
necrosis, sir.
Okay, confluent necrosis can be either not specified, can be confluent, and very severe forms of confluent necrosis is bridging necrosis or panlobular necrosis. Panlobular means entire lobule. Okay, and bridging means from one vascular tree to another. So you have learned these 1, 2, 3, 4 types of necrosis. Another type of necrosis is when the inflammation disrupts the limiting plate and enters the parenchyma. That is called
Interface necrosis. Interface
it's called
piecemeal
piecemeal necrosis
interface
or interface hepatitis. Very good.
hepatitis.
So the type of necrosis are spotty, confluent, and then you have piecemeal necrosis or interface hepatitis. And of course, confluent, when it is severe, it could be bridging or it could be panlobular. Very good, very good. They have learnt all this. So this is how it is. Okay. So this, what type of necrosis would this be? Central vein, portal tract, everything gone. Very few hepatitis.
Bridging.
Uh, uh, okay, you can call it little bit bridging. In this case, this is mainly panlobular. No, the entire lobule has gone. See here, entire lobule, nothing is there. This area may be bridging necrosis. Some hepatocytes are surviving. For bridging necrosis, you must see some surviving hepatocyte. Okay, remember that. For panlobular means the entire, pan means entire lobule has gone. So this is bridging necrosis. You can do an Orcine stain. This is panlobular. Very good. So hepatitis.
Sir, your voice is not coming.
Every 10 minutes is going now.
Yes, sir.
Okay. I don't know, something is happening. Okay, anyway, see, acute hepatitis less than 6 months, chronic more than 6 months. But anyway, this is an figure. This was given by pathologists in 1960s when they used to do liver biopsy for acute hepatitis and chronic hepatitis. they found that the changes of acute hepatitis disappear by 6 months time. And
Sir, you are not audible.
We lost you again, sir.
now,
Yeah.
now,
Yes. Good.
Sumit, okay. Now you see, acute hepatitis, the pathologist told because when they did liver biopsies in 1960s, 1968, it was published in Lancet, that all the changes disappear. So it is acute hepatitis if it is within 6 months. Beyond 6 months, if the changes are there, it is chronic hepatitis. But you know, nowadays a patient of chronic hepatitis may give 2 months history, 3 months history, and
Sir, we lost you again. We lost you again, sir.
am I back? Now am
Yeah,
I
you're
back?
back.
Why is
I
it
think there is,
happening?
sir, I think something in the wire. Sir, why do you need to use these earphones? You can't do without earphones.
I can do it.
Now we can't hear you. Sir, can you unplug it? Unplug it from the computer totally. We can't hear you now. Yeah, yeah. Yes,
Now you can hear.
we can hear you, but it's a feeble voice. Can you make your loudspeaker full volume?
Full volume.
Now it's better, sir. Okay, I think. Let's see.
Now is it okay, Sumit?
Yeah, we can hear you.
Now the computer is on my face. Is it okay?
We can hear you, sir. Surely.
Arre,
We can hear you, sir. But if you are comfortable with the earphones, then use that.
in that. Okay, anyway. Right. So now acute hepatitis conventional. How many of you have suffered from jaundice? Among the 10 of you, anyone? None, no?
Yes.
Huh? None of you, childhood. You know, we did a study and in Delhi schools, you know, there are a lot of studies. By the time you are in 11th or 12th standard, whether you are in a public school or a government school, almost 90-95% would have had hepatitis A, at least earlier. When now, at least, because it will come like a small flu or something and go away. You will never even know that. So, but anyway, now I think most of you are come from very good, very enclosed and nicely good environment. You won't have suffered. But most of us suffer from conventional acute hepatitis and almost 99% recover. Now about 1% will go into acute liver failure, and that is what? You'll have panlobular massive necrosis or extensive bridging necrosis. Most of the people die, almost 40 to 50% in good institutions also, unless they undergo a liver transplant. Now in India, Pakistan, Bangladesh, and then Sri Lanka, all this, Malaysia, Indonesia, Taiwan, and all, no, some people, they have acute hepatitis. After within 6 months, it doesn't subside. A spleen which was not there becomes palpable. They develop pedal edema, they will develop ascites, and they gradually go downhill. That is, and all of them, if you biopsy, you'll find acute hepatitis with bridging necrosis in almost 85-90% of cases. That is a peculiar type. It's called subacute hepatic failure. Now, you know, this bridging necrosis used to look like cirrhosis in low power, if you see in the first one. So many of these people, no, in the West never believed that. It all came from Asian. We attended meeting of acute liver failure. I was there in that international committee. We told that it's all subacute represented and all. Two of the people resigned, you know, from the West. They're talking rubbish. But anyway, now we know that it is, everybody is accepted. Now this acute hepatic failure, within 4 weeks, if you get, they get encephalopathy. Subacute hepatic failure, they get encephalopathy after 4 weeks. So this completes acute hepatitis. So conventional acute hepatitis, only you will get ballooning change.
So something problem with your voice, sir.
Again now.
No, no,
No?
okay, sir.
Oh, the moment you say now, it becomes all right. Please tell now once in a way. Okay. Now this chronic hepatitis, they go into cirrhosis or hepatocellular carcinoma, and of course the prognosis is poor. But fortunately now we have got good drugs for viral hepatitis, and they can be reversed even chronic. Okay. Now let us see, identify this. Who are the people? Anybody from the next batch also can tell what is the first one. This is the high power of the first. What is it? First one, what is it? What has happened to hepatocytes?
So they have become enlarged and the cytoplasms
Very
have
good, very good.
shown some clearing.
That is called
Balloon hepatocyte.
ballooning. Yeah. That is a sublethal injury. The sodium pump has gone. The water inside the hepatocyte cannot be thrown out. So the water accumulates. There is hydropic change, what you call in general pathology, and that is called ballooning change. It has to be 1.5 times larger than the normal hepatocyte to call ballooning change. Okay, so that is ballooning change. Second, what you are seeing here, what is this?
Cholestasis, sir.
The second form of injury you get is cholestasis. Cholestasis also indicates the liver is enlarged. Third form of injury is this, which we saw. What was that? That is necrosis.
Necrosis.
So that is lethal injury. Sublethal injury, lethal. And this is another form of injury. What is that? That is
Steatosis.
Steatohepatitis.
very good, very good, very good. Now you see, when there is injury, I showed you in the first slide, no, adults will have some ceroid pigment. Okay, I told you, no, in the first one, slide, if you see near the central area, get this ceroid pigment is diastase pass positive. The ceroid pigment comes out of the hepatocyte when there is necrosis, and by the time the liver recovers, the Kupffer cells engulf the ceroid pigment. You see, and it becomes this brownish color. If you do a diastase pass, the Kupffer cells will be diastase pass positive. And after some time, these Kupffer cells or macrophages carry all of them into the portal tracts and they are removed. So in the portal tracts, you may find the ceroid pigment diastase pass positive. So when you want to see whether there has been a past injury or recovery phase of hepatitis, you can do a diastase pass and see if the Kupffer cells are containing ceroid. In autoimmune liver disease, other viruses. You cannot distinguish between all of them every time. So you will require clinical history and other things. For example, you can get bridging necrosis, severe necrosis in a case of anti-tubercular drug induced injury, liver injury. Okay, you can get extensive necrosis when you take excessive paracetamol or paracetamol and alcohol together. So you cannot say it is viral or whether it's paracetamol or anything. History is important. So that is what I told, no? The injuries can be almost similar in various diseases. Except you can say in paracetamol, it's mainly centrizonal. Most of the injury is there. Okay. So on and so forth. Right? See, if it is diffuse injury like this, diffuse ballooning change, right? Think of viral hepatitis or acute hepatitis. And mainly in the centrizonal area, ballooning will be more than portal. If there is sharply demarcated necrosis, very sharp necrosis, demarcation, necrosis, demarcation. This is portal tract, so this area must be central. Away from the portal tract, likely to be central area. This is portal tract, away. So you can say centrizonal area sharply demarcated. Think of drug-induced or toxic injury. Okay, then you see the history. Now, yes, Balamitra, can you tell what is happening to this liver?
Yes,
Balamitra,
am I
can you tell me? Balamitra is not there?
there? Sir, I'm there, sir. Sir, is it, hello?
Dr.
Hello?
Ankita, can they hear me?
Hello?
Yes?
Hello, sir. Hello?
Sir, Balmitra is asking to you, sir. She want to reply to you. Balamitra, just wait for a few minutes.
Okay, ma'am. Okay.
Hello, sir.
Yes, Balamitra.
Sir,
Tell me what is that? What are you seeing?
sir, I think it is sinusoidal dilatation, sir.
This one, eh? Okay, we'll go on to higher power, Balamitra. See, this is one core of liver tissue. See, here it has got pinched. Sometimes they use the forceps and all, no? One must be careful. Okay, but you're finding these large, wide spaces, no? Here, okay. So we'll go on to high power. You know these spaces, what are they? Now can you tell? Balamitra? Huh?
It is the same image.
Yeah. What is it? What are they? We'll go on to high power. What are they, Balamitra, now?
Sir, ballooning degeneration, sir.
Yes. There's
Macrovesical.
extensive ballooning degeneration. They're ballooned out, real balloon, no? They're huge balloons.
Macro.
Okay, very good. Ballooning, you're finding cholestasis, and some of the ballooning degenerated cells have got 1, 2, 3 nuclei, 1, 2, or 3 nuclei sometimes. 3. If they have 3 nuclei or more, you can call them as giant hepatocytes. Ballooned hepatocytes with 3 or more nuclei, they are called giant hepatocytes. You know why they are more than 3 nuclei? People feel that sometimes it is a part of regeneration and very commonly seen in neonates when they have ballooning degeneration. You see this? Ballooned hepatocytes, 2, 3 nuclei. And then what is this material? Balamitra, what is this material? Ananya, can you tell
Lipofusion.
what are the, yeah? What is it?
Sir, can it be Mallory?
Melanoma.
No, they are greenish or
Mal-
brownish. No, see this.
Bilirubin pigment.
Yeah, they are all bile.
Hemos.
They're
I
bile pigment, ma'am. They're all bile pigment. Bile pigment can be green, bile pigment can be yellow, bile pigment can be pink also. It depends. You know, you see this? Okay. Yeah, you look at this dot, dot, dot sometimes in the cell. They all bile. See this small canaliculi around the hepatocytes and you're finding bile pigment there. Okay. And this portal tract with inflammation here, right? And some bile pigment is there. Look at this giant hepatocyte. How many nuclei full of this?
Sir, your voice is gone. Hello, sir.
Oh, has it come back?
Yes, sir. It's come back.
I don't know what's happened here. I'll come to Bombay next time. And
Go.
Sir, one question is there in chat box. How to differentiate bile pigment from the steroid pigments? And it is different from lipofusion pigment or not?
yeah, okay. Steroid, lipofuscin, they're all almost, they are similar, you know. Now, the bile pigment is typically green. Now, can you hear better?
Yes, sir.
Okay. Bile pigment is typically green. If it is spheroid, or if it is sometimes little brownish, if it is spheroid or lipofuscin, spheroid or lipofuscin is usually granular. I'll show you some other slides later in the next one. They are very granular and they are not homogeneous like the bile pigment, you know. So this is that is the difference between, you see this, I'll show you. You see this, these are not granular, you know. Sometimes in some cases,
Sir,
very
you are not
granular.
audible.
Oh my God. Now can you hear
Kind.
me?
Yes, sir.
Okay, now. I think it's like a wave, it is going and coming. I don't know, my internet is showing that it's perfect. Okay, right. So in spheroid pigment, it will be very granular. The granules are small in spheroid pigment, just like melanin pigment that you see in the stratum basal of a epidermis. They'll be granular like.
Sir, your voice is again. Hello, sir.
Oh, hello, hello.
Yes, sir.
Okay.
Yes, sir.
Hemosiderin is more coarse. I'll show you hemosiderin also. I will show you all the three together when we discuss a case we have on that. Okay, right? They'll be mild. Now this case two, this is the last one we'll do today. Clinical history: female, 46-year-old, fatigue for 6 months. Raised serum transaminases 5 times. Alkaline phosphatase 180. Viral serology negative. Anybody who will do this? Ananya,
Yes, sir.
you and
So we can.
Sudha are the only third year, or who else is there?
Balamitra, sir.
Balamitra, you want to tell something? Or Ananya will tell?
So we can see
I tell.
multiple cores of liver biopsy, and
Okay,
we
Ananya
can.
will tell half, Balamitra will tell half. Okay, come on.
So there is a few matlab steatotic changes can be seen along with portal tract expansion.
Hmm.
Uh, so there is also inflammatory cell infiltrates.
Okay. See what you have to do, Ananya, you have to say liver biopsy shows 1, 2, 3, 4, 4. This was it. Adequate. Obviously, it's adequate from this. Okay. And then what we are seeing in this low power is you're seeing one is expanded portal tracts with inflammation, right? Okay,
Yes, sir.
number one. And secondly, you're seeing fatty change. Now, whenever you see fatty change, try to identify its location. Now, here the portal tract is there. Okay, here there's portal tract. Here there is portal tract. Here there's portal tract. Now, in this, for example, most of the fat is away from the portal tract, no? Not very near the portal tract. So we can safely say it is likely to be, you can say there is fatty change, but it's more like, more appears to be more near the central region or in zone 3 rather than zone 1. Okay? More 3, it is distributed. The second thing is, you must have heard the lecture on Tuesday. Whenever there is fat, you try to identify what percentage of the liver tissue there is fat. Is it 1/3? Is it 2/3? Is it more than 2/3? Is it less
Yes.
than 1/3 or 1/3 to 2/3 or more than 3? What do you think it is? Notice it is very patchy. This has more, this has even little less, and this has far lesser. How much do you think it is? Here it is
So 1/3 to 2/3.
1/3. Okay, we'll go by what you say. Okay. Now this is the expanded. This this is almost like this uh, like during Christmas you have the uh, leaf which is like shaped like this. Okay, you go to Canada, the flag of Canada is one of them. Will not go into the details. Okay, so this is an expanded portal tract, obviously large one. These are bile ductules here. This must be the arteries, and this might be a vein. This must be a vein. Okay, and you're finding inflammatory cells. What else
Densely
are you seeing? What else are you finding?
Periportal.
Huh?
the
Yes, Anand.
interface hepatitis.
Okay, there is interface hepatitis. Very good. Where is the interface? Is it here? Stop me.
Yeah,
There?
yes, sir.
Yeah. Here there is. And here there is?
Yes,
Okay.
sir.
Okay. Now suppose this is the circumference of the portal tract. You have to say what percentage of the portal tract circumference is affected. Is it 1/4? 1/2? How much do you think? Must be about 1/2, no? See,
Half.
everything all around here up to
Hmm.
here. If you imagine at least 1/2 it is. And then there's inflammation is severe. Is it packed here or moderate or very sparse?
So severe increment.
Yeah, okay, moderate to severe. What else are you
Dense
finding?
inflammation.
What else are you
So
finding? Fatty change and what else?
there is ballooning degeneration of the
Okay, anything else? See, this is the focus of confluent necrosis, isn't it? And this is the
Yes, sir.
focus of small focus of spotty or focal necrosis. So you're finding areas of small foci of confluent necrosis and focal necrosis. So now let us summarize. You are finding an expanded portal tract with moderate to severe inflammation. There is piecemeal or interface hepatitis that occupies approximately 50% of the circumference. Okay. There is evidence of small foci of confluent necrosis and spotty necrosis. Okay. These spotty necrosis will be about 3 or 4 or 5 in a in this profile. In addition, there is fatty change, right? So these are the things that we have seen in this part. Yes, Balmitra. Now this is the higher part of the same thing. We are going there. Okay. What is this nucleus?
1 second, sir. The slide is not moving.
Huh? Balamitra, what is this nucleus? Huh?
Sir, due to glycogen.
Okay. Yeah, these nuclei which look like orphan Annie or like a donut, they are called in the liver glycogenated nuclei. You can see it in a variety of conditions. The common ones are non-alcoholic fatty liver disease, which is fatty liver disease. You can see it in diabetics and you can see it in Wilson's disease. Remember these three at least. Okay. And this is the piecemeal necrosis and all. Let's go on to hyper. Yes, what cells are you finding? Balamitra? Predominantly
Sir, lymphoplasmacytic cells.
no. Predominantly lymphocytes or plasma cells?
Lymphocytes.
Okay. Are there plasma cells?
Yes, sir.
Yes.
Both are there.
Yeah, this is a plasma cell. Nice one with perinuclear hop. Okay. This might be another one. There are some plasma cells. Very good. Let's go on to hyper. Yeah, you see this? This is a plasma cell. Right here, there's another one. These others are all lymphocytes. So you're finding some plasma cell. This is also a plasma cell. Yeah. Okay. I don't know
Yes, sir.
what this cell is. Okay. This might be a neutrophil anyway. Lymphocytes and plasma cells. Are they infiltrating the ducts? That's the second thing you have to see. Whenever you find this, lymphocytes, plasma cells, are they infiltrating the ducts? They can infiltrate the ducts in autoimmune hepatitis. They can infiltrate in sometimes in hepatitis C. In some forms of cholangitis they can see. So are they infiltrating the ducts? Yeah, here maybe. I don't know. This is a vessel,
Yes, sir.
not a duct, because you see this epithelium is not there. Here maybe it's infiltrating the duct focally. Mild. This duct is not infiltrated. This is not. So next thing you have to look is whether the ducts are infiltrated or not. This is the endothelial cells. They are prominent. Nothing there. This might be an eosinophil. I'm not sure here also. But anyway, good. So that's the other thing. And this is an interface hepatitis. So you're seeing. Right? The other thing you have to search is in the periportal area, you find no. Is there any apoptotic cell? Okay. Or if there is any emperipolysis, that's very important. And cholestasis. Three things you have to search for. Is there any emperipolysis? If some lymphocytes entering, be careful. This don't take spotty necrosis for that. But within an hepatocyte, if you find a lymphocyte-like cell, this nucleus, this suspicious. You see here, this one. This is a hepatocyte nucleus. This is much smaller. Maybe there is one emperipolysis. See, you have to search for these things. Whenever it may be there, it may not be there. And see, this is the diastase pass showing the ceroid pigment. Somebody was asking, no, ceroid pigment. It's very granular. You just see, even this in diastase pass, you're finding granules stuck. This small dot granules. So that is why they are very granular. And this is the reticulin stain. What does it show? Reticulin stain. Yes, Ananya, what does it show? Let's say ask Sudha. Sudha, what does it show? Reticulin stain?
There is bridging necrosis. Sorry, bridging.
What?
Fibrosis, sir. Bridging fibrosis, sir.
You see, this is not necrosis. You see this
No,
small
not necrosis,
hair-like
bridging
things, no?
fibrosis.
This
Yeah.
is fibrosis. Hair-like
Mm.
things, they are all fibrosis. See, the other thing that you must see is whenever the reticulin normally in the liver will be like this, irregular. You see this? Cords are irregular. I told you, no? They have to be irregular. When they are becoming parallel like this, no? See this? Parallel chords. Parallel chords means there is loss of architecture. You will never get that normally. Whenever liver cells, I'll show some other cirrhosis. You see here, the chords are becoming parallel. Even if there's no fibrosis, if the chords become parallel, it is abnormal architecture. Okay? Please remember that these are subtle things that you have to see in a reticulin state. Okay? And this Masson's, this also shows fibrosis. Would you require any other investigation? Sudha, Balamitra and Ananya.
Serological
Antibody,
profile.
Huh?
If we serological profile,
antibody
if we
profile, sir.
suspect autoimmune,
Why autoimmune?
ANA,
You don't want to rule out viral. Okay, why autoimmune?
so viral has already been ruled out in the history.
Where? In the history?
Biomarkers are negative.
Oh, it's a negative. It said negative viral serology
Ah,
negative.
how clever. Even then. Okay, anyway, viral serology is negative. Correct. Anything else? You know, there's another point that I think I should have. I'll tell you later. It is there in this. Just observe these areas. 3, 4 hepatocytes together. Okay, in a diastase passage, better seen. You see this? Group of hepatocytes together. Just groups. Eh? Okay, we'll come to that, what they are later. Okay, so you recur. So you're suspecting autoimmune hepatitis, isn't it? All of you?
Yes.
Yes, yes.
Because of
Yes,
the
sir.
plasma cells and lymphocytes. Very good. It looks like autoimmune hepatitis. So you must know the autoantibodies and gamma globulin. So you know, see, whenever you see autoimmune liver disease, the type 1, type 2, type 3 are autoimmune hepatitis, where there is more of hepatitis. Okay. Then primary biliary cirrhosis, that's also another type of autoimmune liver disease, ALD, not alcoholic liver disease, autoimmune liver disease, primary biliary cirrhosis, primary sclerosing cholangitis, and autoimmune cholangitis. Now, how they find out is by the different types of antibodies. We'll not go into the details, except primary biliary cirrhosis. Remember, anti-mitochondrial antibody is important. M2 variant. And for autoimmune cholangitis, ANA and ASMA. Just like lupus, ANA and ASMA. Okay, and primary sclerosing cholangitis, of course, most of the times you'll not get markers. Here there are 3 types: LKM, smooth muscle, ANA, anti soluble liver antigen, and so on, so on. Liver, kidney, microsomal 1, 2, 3. We'll not go into the details of these theoretical things. So basically, you have to know the autoimmune. Please know PBC, PSC, and autoimmune hepatitis. They all
Sir, your voice is not coming. Sir, not
no.
yet. So,
Okay. No, is it
yes,
coming?
sir.
No. Okay. So that's why every portal track look for cholangitis. I told you, no? Just see. So you must have clinical serology, histology. Then only you can make the diagnosis. There are lot of criteria. Will not go into those. But please remember, liver histology should be either compatible or typical of autoimmune hepatitis. Okay. So we'll go to what is uh, typical and what is compatible with autoimmune hepatitis later. We will see what is there. So if there is interface hepatitis, was it there in this case?
Yes, sir.
Then you search for hepatitic rosettes and emperipolysis, which are better indicators of autoimmune hepatitis. Now, I told you I wanted to show you this. These groups of hepatocytes, no, when they are together without a bile canaliculus in the middle, they are called hepatitic rosettes. This is very common in autoimmune hepatitis. You know, search for this hepatitic rosettes even in autoimmune hepatitis. See, if you do a DAS pass or something, it comes out very well. You see these groups of hepatocytes clustered together. This is known as hepatitic rosettes and emperipolysis. That's very difficult to see. If you see, it's supposed to be a very good marker. Now, if you have all three together, then you know it is typical of autoimmune hepatitis. Interface hepatitis with lymphocytic or lymphoplasmacytic infiltrate, hepatitic rosettes, and emperipolysis, all three. If you have if you just have features of interface hepatitis without all these things, then it is compatible with autoimmune hepatitis in a particular clinical situation. Serology positive and other
Sir, you are not audible.
Now can you hear?
Yes, sir.
If none of these three things are there, don't call it autoimmune. If interface hepatitis alone is present, say it is compatible provided the serology is positive. If all three are present, then it is
Typical.
Sir,
Sir, your voice is not. No, sir, we can't hear you.
now can you hear?
Yes, sir.
Okay. How is emperipolysis different from phagocytosis? Anyone? Anyone? Chat box.
The
Okay,
cell
okay.
remain alive in emperipolysis. Live
Excellent.
cell is there in
Who's that?
peripolysis.
Grishma.
Yes,
Grishma?
sir.
Oh, very good. Very
Yes,
good.
sir.
That's the answer. In phagocytosis, there is lysosomal degradation of the engulfed cells. In emperipolysis, one cell is taken in by the another. Okay. There is one thing called entosis, in which there is a non-apoptotic programmed cell death inside. Okay. So you have emperipolysis and phagocytosis. Will not go into the details. There are different kinds of entosis, you know. You can have efferocytosis, you can have suicidal emperipolysis, enclysis, entosis. All this you just remember the names and read for your exams. Some short note somewhere may come. Okay, right? For example, emperitosis is a type of emperipolysis which was given for a natural killer cell invasion of tumor cells. You know, so they gave some name there. So, so you can efferatosis is a specialized form of phagocytosis in which almost dead cells are engulfed. In phagocytosis, they are engulfed and the lysosome degrades it. So, efferocytosis is a specific type. And when the adjacent host cells, one liver cell engulfing another liver cell, that is called entosis. That is a non-phagocytic cell taking in another adjacent cell. Okay, so these are some other names that are given. You see, now here you are finding some emperipolis here, and interface hepatitis is very important, and it is usually very severe in autoimmune hepatitis, more severe than in chronic hepatitis. This is one thing very important. Plasma cells, what percentage you will find in autoimmune? Ankita can tell in what percentage they are writing in the chat box. I didn't put the stopwatch. Okay, what percentage? A, B, C or D? Maximum?
A, sir. Three
A.
answered A.
A.
Three.
Okay. Most of them feel A. The answer is only in 2/3 of
B.
cases. Okay. Mostly they are IG positive. IgG. If you find IgM, suspect primary biliary cirrhosis. If you do IgG staining and IgM staining, and if you are not finding any granuloma, anything, but you're finding a lot of IgM positive cells, it's not Waldenstrom's or any of those other things, think of PBC, suggest PBC in your diagnosis. Okay, you can find eosinophils also, and you will find these rosettes. Rosettes are of two kinds. Hepatitic rosettes, you will not find a canaliculus in the middle. This is a cholestatic rosette. Where you find hepatocyte with a canaliculus, you may find bile. This is a hepatitic rosette where you don't find any canaliculus. Group of hepatocytes. Very frequent in autoimmune hepatitis. If you find lot of hepatitic rosettes, think of autoimmune hepatitis. They are found in almost half of autoimmune hepatitis. Very rare in chronic viral hepatitis, and in pediatric age group, very common if there is autoimmune hepatitis. See this? These are all hepatitic rosettes. Hepatitic rosettes. This is very important. Emperipolysis. Search for emperipolysis. Very important in autoimmune hepatitis. If you search, you'll find it in about 2/3 of cases. Remember, plasma cells in common in 2/3, emperipolysis common in 2/3. But invariably, the case that you see, you'll not find either of these. See this? And cirrhosis is very common in autoimmune. They are much more common than in viral hepatitis. But the good point is, you can, if you treat early, the fibrosis can regress. This is one of the excellent prognosis that you get of fibrosis. You can get very severe hepatitis in autoimmune. You can get extensive necrosis in about 1/3 of cases and acute liver failure. Look at this.
Sir, your voice is not coming.
Again.
Yes, sir. Now it's
Now it is there. So
yes.
anyway, you can score the amount of inflammation and other things. We'll come to that later. And you can give a report. So there are a lot of differential diagnosis. It can mimic many things. Once again, clinico-pathological correlation is important. Okay. Can anybody identify this cell? Anyone?
Ground glass appearance.
Yes, yes, ground glass. In ground glass, the cytoplasm is homogeneous. Usually the nucleus is pushed to one end. It's usually found in one end. Okay? It won't be central usually, it's pushed. And you see this one, partly it has become ground glass. These are all hepatitis B surface antigen. You can do an HBsAg staining and a core antigen staining. We'll come to that later. This is hepatitis C, in which you get my portal inflammation and fatty change. So that's how you diagnose. Then see hepatitis B, chronic hepatitis, you will find ground glass hepatocytes or HBsAg or HBcAg. Okay. In acute hepatitis, you will never find HBsAg. Never, never, never. The only time when you find HBsAg in acute hepatitis is when there is severe immunosuppression, as in post-transplant patients, patients receiving chemotherapy, or a special type of acute hepatitis in which you get fibrosis very early. That is also in immunosuppressed individuals. That is called fibrosing sclerosing hepatitis. Okay, so that is another type, rare type of hepatitis. Other surface antigen, if you find, it means chronic hepatitis. Keep that in mind. Not core. So once you do, you have to grade and stage. How do you grade and stage the inflammation? Grading is inflammation, staging is fibrosis. There are different types of grading systems. One is the International Liver Group, in which the grading is done by A, B, C, and D. Periportal inflammation or interface hepatitis, confluent necrosis, focal necrosis, and portal inflammation. Total, if you add, you get 18. Then staging, 6 stages. 0 is fibrosis, 6 is cirrhosis. That is one type, right? There are, now see this liver biopsy, you are finding this is lot of cholestasis, no? With inflammation here. So there is cholestasis and bile duct destruction in about 10% of autoimmune hepatitis. Routine autoimmune hepatitis. In cholestasis, you have done this stain. What is this stain? We'll finish now. What is this stain? Anybody? Ankita, anybody has mentioned anything? What stain is this?
No, sir. Let's see.
Copper.
Copper.
Who said copper? Ananya. Anybody else? Somebody said bile. Ah, yeah, this is the road stain for copper. It stains copper. Orcine stains copper binding protein or copper associated protein. Please note one thing. This copper and all iron and all metallic pigments, they are drained into the bile. So you see, this pigment will be more often in the canal. This is the sinusoidal pole of the liver cell. This is sinusoidal pole of the liver cell. This is the canalicular pole. You see, they are in between. This is the canalicular pole of adjacent liver cells. They are more often found in the canalicular pole than elsewhere. See, this is the sinusoid, a little away from the sinusoids, mainly in the center. This copper stain. You get that when there is biliary obstruction because it doesn't get excreted, right?
Sir, your voice is coming. Hello, sir.
Hear me? Can you hear me?
Yes, sir. Yes.
Okay. While when you see more than 5 profiles of these bile ducts in a portal tract is bile ductular proliferation definite. This is ornithine stain copper associated protein. This is rhodonine stain for copper. You see, this will all be in the canalicular pole. This is the sinusoidal pole, canalicular pole. I showed you in the beginning, no? Sinusoidal, this is the canalicular pole. Okay? So please remember, they can have overlapping features with PBCs, primary sclerosing cholangitis and other things. There are various criteria that you need not know. And please remember, HLA-DR is positive in
Sir, your voice is gone. Sir, we can't hear you.
now can you hear?
Yes.
Okay. See, HLA-DR will be positive in the bile duct epithelium in primary biliary cirrhosis and autoimmune cholangitis. ANA homogeneous seen in autoimmune hepatitis and overlap between autoimmune hepatitis and primary biliary cirrhosis. ANA dotted is seen in primary biliary cirrhosis. Homogeneous for autoimmune hepatitis, dotted for primary biliary cirrhosis, HLA-DR in primary biliary cirrhosis and autoimmune cholangitis. Primarily biliary disease, autoimmune cholangitis, primary biliary cirrhosis. Primarily hepatic disease, autoimmune hepatitis, you get ANA homogeneous. In ANA dotted, you get in primary biliary cirrhosis. Keep this in mind. See, you see this? What is this? This is a
Granulomas.
yes. It's in the portal tract, no? This is an artery next to the artery. Can it be tuberculosis or is it primary biliary cirrhosis?
So one is answering primary sclerosing cholangitis.
No, you will not get in primary sclerosing cholangitis. If you see granulomas, think of PBC or tuberculosis. If you find lot of plasma cells and eosinophils, it could be drug induced or PBC, that is higher than tuberculosis. Okay, you may get it in autoimmune hepatitis, but they're more common with PBC. They're more common in AIH with PBC overlap syndrome. Okay. Primary sclerosing cholangitis, you will get loss of bile ducts. The bile ducts become beaded like this, an obstruction. And if you do a liver biopsy, it depends which bile duct is abnormal. If it is the small bile ducts and your liver biopsy hits that, you will get the typical onion rings appearance of primary sclerosing cholangitis. If it affects one of the larger ducts and you are doing the biopsy upstream, then it will look like a biliary obstruction. If it has affected the left ducts on the left side, and we do liver biopsies mainly on the right side, you will find a normal biopsy. So in primary sclerosing cholangitis, you may get typical findings of onion skin in the smaller portal tracts. You can get the finding of a biliary obstruction if downstream the ducts are affected and these are not affected, or it can be normal if biliary tree that is sampled is not at all affected. So you can get three things. Therefore, a biopsy is never the gold standard for diagnosing primary sclerosing cholangitis. It is always imaging. So don't worry if you cannot give a positive diagnosis of primary sclerosing cholangitis. It is always by imaging, right? This is the typical onion skin appearance seen in primary sclerosing cholangitis. Later, the bile ducts will disappear. And how will you do that? You find portal tracts with arteries, and out of 10, less than 5 have got bile ducts. That means there is paucity of bile ducts. That happens in primary sclerosing cholangitis. The other features are of cholestasis. You see, you can get cholestasis in the centrizonal area, bile duct proliferation, cholestasis in the canaliculi. This will be a canalicular rosette almost with inflammation, or you get bile infarcts. That is necrotic area encrusted with bile. These all indicate large bile duct obstruction. Please remember, whenever there is bile duct obstruction, there are two things. One is the bile pigment will not flow. Second is the bile salts will not flow. When the bile pigments do not flow, you get a green color that is called bilirubinostasis. When the bile salts do not flow, you call it cholate stasis. And the bile salts are toxic to liver cells, and that is what causes inflammation. Bile pigments will not cause inflammation, the bile salts cause. That is cholate stasis. Bilirubinostasis, cholate stasis. Bilirubinostasis can be seen because of the green color. Cholate stasis is seen because there is biliary, there is necrosis, inflammation, and so on. You see, CK19 is the stain for bile ducts. Okay. Remember, there are two stains, CK7, 8, and you can do anyway 9 will go to that. This is bile duct infiltrated by neutrophils, indicating cholangitis. This is fibrosis, biliary type of fibrosis. So you can, there is a spectrum what you get in all this. Okay. So case 2, adequate liver biopsies with maintained architecture, moderate interface hepatitis involving 5 of 7 portal tracts associated with moderate to severe portal inflammation composed predominantly of lymphocytes. Plasma cells and occasional eosinophils are also identified. Ductular cholestasis and cholangitis are absent. Lobules show diffuse ballooning change. There are numerous hepatic rosettes, spelling in the periportal area. Few areas of spotty and confluent necrosis are identified. Occasional hepatocytes show emperipolysis. There is no cellular canalicular cholestasis. Granulomas are not seen. Special stains reveal marked portal fibrosis, etc. Immunohistochemistry, we have done negative. Histological features is consistent with autoimmune hepatitis, definite with significant fibrosis. Definite or typical. Histological grading we did. Histology. This is how you have to do. Okay. So with this we stop today. Tomorrow 11 we will continue. Any
So there,
questions?
so there
Anything?
are two questions in chat box.
Yeah.
One is how reticulin stain will show up in normal liver.
Okay. That's coming up. Just after this. I'm coming up with reticulin stain. Yeah.
Second one is what are the
Definitely.
3 things to be checked in periportal areas and its significance?
3 things.
Second,
Means,
in relation to autoimmune.
yeah. Please tell me. Kusum, yes. Tell me, please. What I couldn't follow 3 things.
3 things
Periportal.
to
Okay, periportal area. You just see the amount of piecemeal necrosis or interface hepatitis. C for emperipolysis. C for apoptosis. C for cholestasis. These 3 things you have to see. And of course, hepatic rosettes you can find both in periportal, midzonal, or zone 1 and zone 2, or periportal and midzonal areas. So all these 3 you have to C for emperipolysis, C for apoptosis, okay, C for hepatic rosettes, C for cholestasis, and of course, any other thing you want to. Next time we'll go a little faster. I'll come to the more detailed ones, and there are several cases that we see. We won't be able to discuss all in detail, but we'll go fast. Is there anything you didn't understand all this?
Sir, there's a question like,
Yeah.
is 0.8 millimeters into or centimeter in a quarter? Sir,
I'll stop sharing. Let me see. Stop sharing. Yeah. Here we are. Okay. Tell me now.
do you repeat this 0.8?
Yeah, tell me please.
Yes, could you repeat?
Ankita, I can't hear.
Sir, actually, Lina madam is saying something, but voice is not audible.
Madam's voice is not audible. I'm so sorry, Ankita. So many times my voice went off. I really don't know. I've tried 101 things. Anyhow, next time I'll have to call some computer expert to explain to me. Yes, these boys and girls, is there? Can I see your faces if they're around? Yeah, is there anything you all didn't understand, want me to explain anything else?
Can you hear me now? Sir,
Yes, yes, little better now. Dr. Lina. Again, it's going off.
Yeah, Lina, your voice is breaking.
Sorry, sir.
Sumit, I'll have to take Sheetal's laptop. That's the one with a good voice.
Yes, sir. I think it's an excellent session, sir. And we have almost reached what time? What's the time now? Is 9:30. You've been talking since 6:30 p.m. 3 hours. It's gone very well.
No, I hope these people understood something. That is the main thing.
I'm sure, sir. There are still 82
Otherwise,
audience.
no point in talking. Eh?
So no, everybody enjoying it. You can still see that there are comments in the audio. There are so many compliments there on the chat box, and there are still more than 80 students in the room. They're not leaving you.
Oh.
So, but are there any pressing questions, Aarti?
It is it's not up to this session, but
Okay.
we'll try.
I think. Do you have any, sir? Anything you want to say finally? Any final comments for students?
Sumit, 1 second. Let me try another thing.
Students, do you have any questions, or you want to go and have your dinner now?
Yeah, I think they want dinner. You're most welcome, students. Anything you want specifically for next time, you tell me, please.
Sir, I think they don't have any questions. And you have anything?